will be bringing the jury. Traditionally, they'll say, all rise, stand up, and then I'll sit you down.
Very good.
I texted him.
Who's David?
Yeah. Everybody's not quite back yet.
So you want me to go see if he's up there?
No, I can do that.
I was looking for her kids. I was like, just to discharge somebody. She's in candidate 7. She's had a market here for her, or for her.
I love it.
I showed my dad the dollar sport room, and he was like, wow, that is a lot smaller than here. He was surprised at the different sizes.
And this what we used to call the bowling alley. It was 9B, and it was longer, probably just a little bit longer than this main area here without the box. But the jury was like situated over here away from the judge, so they had their own entrance in and out of the jury. It was a good room to try a case.
All the big ones were there back in the day.
Hard to believe we've been here over 11 years now.
I can remember, well, the Ucker case was in there. Jim O'Grady prosecuted David Ucker. It's a big deal. That's
We
all right.
had 270 shooter was in there. And then Buzz Lukens. Remember how they had the whole back of the building just lined up with the media?
All rise. Please be seated.
Ladies and gentlemen, I hope you had a wonderful lunch. Doctor, you are still under oath.
Yes.
Ms. Bucher? Bucher, getting closer.
You got it. Thank you, Your Honor. All right, Dr. Moody, before we took a break for lunch, I believe we were talking about medication.
Okay, yes.
I do want to come back to that, but I also want to finish up the pre-extubation stuff
Okay.
we were talking about. So can you talk to me about agonal breathing?
Sure. Just describe it to you, or?
Well, how do you explain, first of all, do you explain that to the family members?
Yes.
What do you tell them?
Make them aware that it is possible that they may witness their loved one experience what we call agonal breathing. And again, these are individualized symptoms, so it's hard to generalize, but when somebody is at the end of life and taking those final breaths, it can be agonal, meaning there can be some distress where their work of breathing is increased or appears distressful. In most cases, it's harder for the family to witness that than it is for the patient to experience. Most patients are not aware or in distress, but it can be visibly hard for the family to see, and sometimes it can be distressful to the patient, and in those cases, we administer medicine.
Okay, doctor, what is it? I mean, we're not doctors.
Sure.
You use that phrase, what do you mean?
It's distressed breathing associated with typically the end of life.
Okay.
And you said it appears to be painful, is that what you said?
It can,
Judge, leading.
It is. New question. All right, same question, just done right?
I'll move on. So do you explain this to family members?
yes, we'll make them aware that it's something they may see.
And you said sometimes you provide medication for this?
Yes,
What medications?
most often morphine
Okay,
in my practice.
okay. And going back to medication now, you've already explained the order set and how you do it.
Yes.
Do you then order the nurses to administer? Or how does the medicine actually get to the patient once you've ordered it?
So once those orders are in, there is typically a dose of the medications, most often morphine, sometimes or frequently in combination with Ativan. There is typically an order for them to give a dose of that morphine before the tube comes out, so that is a definite order that they will then give. After that, the orders are what we call PRN, which means as needed. So then based on the patient's needs. Some patients may not need any further doses, some may need frequent doses. That's, again, patient by patient.
How much do you order beforehand for the patient to be given?
I mean, again, there's some variability.
Relevance.
I'm sorry?
Relevance.
Overruled.
My standard practice is anywhere from 4 to 10 milligrams of morphine.
And post-extubation, what do you generally prescribe?
And again, we're generalizing, so I can't say, that there aren't cases where more or less is ordered. Probably, and those are every 15-minute doses, typically 2 to 4 milligrams.
Again, we're speculating.
Okay, overruled.
Go ahead.
Those 2 15-minute doses are typically start at 2 to 4 milligrams, but up to 10 milligrams would not be outside of the bounds of what I've ordered.
And that's of the morphine.
Correct.
How about benzodiazepine?
Typically, I use Ativan. Versed is another alternative for benzodiazepines. In my practice, I'll use Ativan, typically 2 milligrams.
And is that something that you continue to medicate with as well?
Only if it's needed, but in the circumstances where it is, yes.
But it's possible?
Yes.
Now, are you aware of what a Pyxis machine is?
I am.
And do you have any understanding of how it works at all?
I've never, it's something that the nurses and pharmacists use. I have some idea, they enter something and the medications come out, but
Okay.
no.
Are you familiar at all with the override function of a Pyxis?
Other than that it exists, I'm not.
Okay. Have you ever ordered a nurse to use the override function for any purpose?
Yes.
What purpose was that for?
The one that comes to mind are vasopressors. So those we talked about are medications that help support a patient's blood pressure. So in circumstances where a patient is suddenly very unstable, I need those medications, those vasopressors, very quickly. So I will ask the nurse to basically get out of the Pyxis whatever vasopressor you can get the quickest to save that patient.
And have you ever ordered a nurse to use the override function for a palliative extubation?
No.
And why not?
Well, I guess because it's not an emergency. So the cases where we are using that are those examples I gave where there's a really emergent need and I need that medication at that moment.
Now, you've stated that your preferred medication is morphine and Ativan, correct?
In my practice, yes.
Yes, this is in your practice. Do you ever use fentanyl in your practice in any way?
Yes.
And what do you generally use that for?
Two uses. One is in patients in the ICU when they're on a ventilator to maintain their sedation. And it's very commonly employed in those cases, either as a bolus dose, meaning we'll give it through the IV, and a push dose, or with a continuous infusion, meaning it runs slowly over a continuous period of time to maintain the patient's sedation. The other time, I'm sorry, is in procedures where we'll use it.
Okay. And are you familiar with what the conversion factor is from fentanyl to morphine and vice versa?
Yes, I am.
What is that?
I believe it would be 10 milligrams of morphine is equal to 100 micrograms of fentanyl.
Okay. So have you ever used 100 milligrams of morphine for a palliative extubation?
Sustained.
I'm just talking about her practices.
No, that wasn't what you asked.
Have you ever used fentanyl in any palliative extubation first?
I haven't personally, no.
What is the highest dose you can recall giving of morphine for a palliative extubation?
No.
Objection.
Strike the question.
Can we approach, Your Honor?
Yeah.
All right.
You guys busy back there? I ain't hearing anything.
No, I still can hear it.
Mr. Bias.
Feeling when I get home tonight, it'll be gone. Yeah. And I'm going out, you know. So they didn't have the same
Well, you're not on, so she has to.
I was just talking to George.
We still need her to get set up. Okay. Rephrase the question.
Thank you. So in reference, so we're going back to the conversion between morphine and fentanyl. In your practice, have you ever used 100 milligrams of morphine during a palliative extubation?
Objection has been answered.
Overruled.
Thank you. Have you ever given in your practice 50 milligrams of morphine for a palliative extubation?
No.
And if my math is correct based on what you said, what is 50 milligrams equal to in
Of fentanyl, you mean?
fentanyl?
Unsustained.
Have you ever given in your practice 25 milligrams of morphine for a palliative extubation?
And to clarify, you're referring in one single
Okay,
dose.
hold on. When we have an objection, I gotta kind of gag you in a minute, okay? You're just going on your usual?
I'm sorry, I didn't hear it.
You said objection, I stopped the witness, and I came back to you because I'm deciding on which way you are going with
Same
this.
objection.
I'll let her answer.
Also asked and answered.
I will let her answer. Go ahead and ask it again.
Thank you. Have you ever given 25 milligrams of morphine during a palliative extubation?
And to clarify, you're talking in a single dose, correct?
Yes.
No.
And in your practice, what is the largest dose of morphine that you can recall giving to a patient for a palliative extubation?
Objection.
Sustained.
When you, let's talk about post-extubation, the medications that you give. Do you order all of the medication at once for your pre and post-extubation process?
Typically, I will order,
Objection, leading.
I'm going to let her have it on transition. You can answer.
I will order what we talked about, the PRN or as-needed dosages, but I may adjust these in real time based on the patient's needs.
What types of things would lead you to adjust?
If we were not meeting the patient's needs, for instance, that they were experiencing symptoms of distress or clinical signs of distress, I may increase the dose. Perhaps I may decrease it as well if I did not feel that they needed a dose that I had ordered.
And do you instruct the nurses on how much to administer?
I place the orders and then they follow those orders.
Okay, and just for clarification, what is in the orders? So you, obviously the
Okay.
dosage.
We've been through this before.
Okay,
Let's move on.
all right. All right, let's talk about progress notes.
Okay.
Can you tell the members of the jury what are progress notes?
Objection. Answered.
I'm sorry.
Asked and answered.
Yeah, she discussed it earlier today. And she was talking about the difference, the notes and the night and everything else.
So the reason I'm asking is it's a transitional question. I have an exhibit. I just wanted to
Now we'll just go to the exhibit.
All right. Just from Belisari's records. May I approach the witness, Your
You
Honor?
may.
You can just. And I'm handing you what is marked as State's Exhibit 1C.
Okay.
And you can hand that back to me whenever you're ready. Do you recognize this?
Sure.
What is this?
It's part of a progress note.
Okay.
Yeah, it's one page of one.
And what's the name of the patient? Sorry.
Oh, I'm sorry. It's Ms. Joanne Belisari.
Your Honor, may I publish?
You may. If there's no objection.
No issues. Go ahead.
So, is this what I just showed you here?
Yes.
And can you explain to me the reason there's this language here in the progress note?
I guess two reasons. First, it sort of sums up a situation, and then when we are billing for critical care time, which is simply how we bill patients that are critically ill in the ICU, the billing guidelines stipulate that we put a statement in there explaining our critical care time and then how much time we spent with the patient.
Okay. So it says life support measures, and then the last part, without which she would not survive.
Correct.
Are you, in this record here, are you opining at all to her prognosis?
No, that is a real-time statement. So just in that moment, on that day, the patient would not survive without mechanical ventilation or vasopressors.
Okay, thank you. Now, I would like to go back to November of 2018.
Okay.
Is that when you became aware of the allegations against Dr. Husel?
Yes, late November, yes.
I'm sorry?
It was later in November, the day
Okay.
before Thanksgiving.
And how did you learn about the allegations?
As I mentioned, it was the...
Objection, calls for hearsay.
I'll let you have it. How'd you find out?
I was away, it was the day before Thanksgiving, and I got a call from my office manager.
Okay, that's enough right
Okay.
there.
And without telling me the specifics of the conversation or what exactly was said by the other person, what did you learn?
Okay. I mean, there were a couple steps in between there, but I learned that the prior night, which would have been Tuesday night, that Dr. Husel had administered...
Objection, hearsay.
I'll permit it.
That Dr. Husel had administered 1,000 micrograms of fentanyl and 10 milligrams of Versed in a palliative vent withdrawal situation. And this had elicited concern, and therefore he was going to be placed on a leave while the hospital investigated.
And I think I know what you were trying to do when you're trying to give the information before. Why is it that you would be made aware of this?
Dr. Swanner is the one who had reached out. He was trying to reach Dr. Ralston, who was my partner, who was the medical director of the ICU at the time. Again, right before a holiday, Dr. Ralston was on vacation, his cell phone was off, and therefore I reached out to Dr. Swanner, not knowing what the situation was, but basically, is it something I can help with in the ICU? And then he disclosed to me what I had told you.
So Dr. Swanner contacted you?
No. Is it okay if I go through the steps?
No.
Okay.
Okay. After you became aware, did you at any point reach out to Dr. Husel?
No. Well, not at that point, no.
At any time after that?
Dr. Husel reached out to me in early December.
Okay. Did you ever send any messages to him?
In January, that was after news broke, so to speak, of the story.
And what was your purpose for reaching out to him?
He was a colleague and somebody that I had liked, respected, worked with for 5 years at that point. And it was upsetting to see what he was going through and his family, so it was reaching out in that capacity.
And you said it was in January that you sent a text message?
Correct.
When you sent that message, were you aware of the full extent of the allegations at the time?
No, I was not part of the investigation. I was aware of scuttlebutt, but I had not been privileged to the investigation itself.
Okay. Nothing further.
Cross?
Please report. Madam Prosecutor. Good afternoon, ladies and gentlemen. Good afternoon, Dr. Moise.
Hi there.
Pleasure to meet you. This is our first time speaking, right?
Yes.
Okay. I'm going to ask you some questions. If you don't understand the question, just ask me to repeat it. Sometimes I have to follow the way of saying things, okay? All right. Having said that, we kind of bounced around quite a bit during your direct, so I'm going to try and do the same thing, okay? All right. Now, you said that when the process of, before the process of the extubation begins, that you have a conversation with the family, right?
Yes.
Remember that line of questioning? Okay. And you said, and I wrote this down, that the whole situation is very sad.
Of course.
Okay. And it's not an easy thing to do to speak to a family about the potential passing of their loved one, I assume.
Sure.
And it's also not easy for them to hear it. Correct?
No, it's, yeah, very sad.
This lady over here is taking down everything to say, and you have to verbalize it. I'm not picking on you.
Oh, sure.
I just have, if
No, I agree with you. It's very sad.
instruct you to answer, okay?
Sure.
All right, so sometimes it's not easy for them to hear, right?
Right.
And in fact, these conversations are sometimes had multiple times, correct?
Yes, that's true.
Okay. And that can also include other doctors having that conversation.
Yes, yeah.
And you went over in your testimony some of the things that happens during I guess, a terminal extubation, like the agonal breathing, correct?
Yes.
Now, fair to say, when someone is being taken off the ventilator, the oxygen levels, there's a huge difference in the oxygen levels, correct?
Do you mean in the oxygen being delivered to them?
Correct.
Yes.
Okay, so essentially when we're breathing in this air, it's 21%, right?
Right.
And we're getting 21% oxygen at this time in this room.
Correct.
When they're on a ventilator, that's 100%, right?
Only in the worst cases. It may be as low as 30% in somebody who's not requiring as much oxygen.
But many times it's much higher than room temperature.
Oh, of course, yes.
Okay, so there's the adjustment to that a patient has to make, right?
Yes.
And you mentioned the agonal breathing. That also affects their reserves, correct?
Could you rephrase that maybe?
Sure. When someone is agonally breathing, they are utilizing their reserves to go above and beyond and breathe extra, right?
Yes, that's correct.
Okay. And for the jury to help follow along, a person can tire out by agonal breathing, right?
Yes.
Okay. And if they tire out agonal breathing, they stop breathing, right? You have to say yes or no.
Yes. Sorry.
Okay. And I can't see your lips because
That's true, the mask.
It's okay. I understand the reason behind the mask, so forgive me if I ask you.
Sure.
So a person can tire out, and sometimes they die sooner because they tire out due to the agonal breathing, right?
It's a very individual
We're going to get
case.
into patient specifics,
Yeah.
but that's a scenario that sometimes occurs, correct?
There's the potential for that, yes.
Okay. And there's other things, other distress that a family may have to suffer when seeing someone extubated, correct?
Sure.
Some of them will be, for example, the death rattle. Are you familiar with that?
Yes.
Okay. And can you tell the ladies and gentlemen of the jury what a death rattle is?
It relates to the secretions that we all tend to produce, but at the end of life cannot manage, and therefore it will create this rattle due to the secretions in the back of a patient's throat that are pooling there.
And that could sometimes sound like boiling water, right?
It can. Again, it varies. It's not always this dramatic.
And in addition to that, a patient can also cough up blood.
They can. That's not a common occurrence.
In addition to that, one of the other things that they can do is have foam coming out of their mouth, correct?
Yes, I suppose. Again, these are case-by-case type things.
All of these things are very distressing to see as a family member, right?
Sure.
And there's nothing you can do medically to erase those memories, those last moments from the patient family's minds, can you?
No, but we do want to meet our patients' needs, so we manage those symptoms to the best of our ability.
Right, and that's one of the things all these things that I just mentioned are things you try to think of ahead of time, right?
Yes.
Okay, and obviously you don't want your patient going through these things, correct?
No.
And you also don't want their family seeing these things, right?
No.
Okay. Now, you mentioned that you utilize an order set that we've heard quite a bit about in this trial. Do you recall that testimony with the prosecutor on your direct?
Oh, yes, yeah.
Okay. Now, again, these are not, or at the time in question in this case, these were not mandatory in any way, shape, or form, correct?
No, they were not.
In fact, different doctors have different preferences based on their training as to what drugs they like to use during the palliative extubation, correct?
Yes.
Okay. And you're, I believe I heard you say you're an internal medicine doctor?
Yes.
Okay, so you studied, you're board certified in internal medicine?
Right.
Okay. And you're aware that Dr. Husel's background is anesthesiology, right?
Yes.
So his background and training naturally differs from yours.
That's right.
Okay. And his familiarity, I knew I was going to bundle up the word. And it's a simple one. His familiarity with certain drugs may be different than yours.
Yes.
Okay. Now, may I approach the witness judge with these three?
Yeah.
I'm going to show you state's exhibits 17A, B, and C.
Okay. Thank you.
Dr. Mooney, can you tell the ladies and gentlemen of the jury if fentanyl is on any one of those order sets?
If you don't mind just giving me a minute here.
No, not at all.
Just a page. I don't see it on these two. I'll look at this one. I don't see it listed on any of these.
I don't understand.
Okay, is that a question?
I'm gonna, yeah. Are you, you're aware this case is about fentanyl, correct?
Right.
And you've been shown these order sets in the middle of this trial, but yet they don't have any mention of fentanyl in them, do they?
No.
So if I'm a doctor and I choose to utilize a different drug other than those, that's what's on those order sets, at the time in question in this case, I could have used those drugs, correct?
Yes.
Now, you mentioned something about vasopressors and how at times you've utilized nurses to get to, or you've instructed nurses to override the PICSA system to get vasopressors, right?
Yes.
And that's because vasopressors are a form of life support, right?
They are.
And they help the heartbeat.
Yes, and they increase the blood pressure.
They increase your blood pressure. That is a thing. Vasopressors also, they're forgive me, it's been a long day. Vasopressors act quickly, right?
Yes.
Okay. And vasopressors are one of the life support measures that are utilized in the ICU.
Right.
Along with a ventilator. Okay, you have to say yes.
Yes.
All right. Now, vasopressors are also fast acting when you turn them off, right?
Correct.
So if a patient has a vasopressor and you turn them off with the extubation while you're extubating a patient, it's 1 to 2 minutes, right?
It depends how much of that medication they're on.
Okay, but if they're maxed out on vasopressors and you turn those off, that blood pressure may dip quickly.
Typically it does. There have been exceptions. Sometimes patients do things differently than we expect.
But typically it does.
Yes, yeah.
Okay, and that could immediately affect the heart to stop.
Correct.
Now, you were shown States Exhibit 1C. Do you recall this?
Yes.
And for the record, it's 1C. And we're talking about Ms. Balasari.
Right.
And you state here, she's on full life support measures, including mechanical ventilation and vasopressors, without which she would not survive, correct?
Right.
Now, if you take her off the mechanical ventilator and you turn off the vasopressors, that would hasten Ms. Balasari's life, correct?
Sustained.
You're saying here that she won't survive without this ventilator, correct?
Correct.
And she won't survive without these vasopressors, right?
Correct.
So if she doesn't have them, she's going to die.
Yes,
Okay. And these two things are keeping her alive.
that's correct.
So if you take them off, it's going to hasten her death, right?
Sure.
And that's essentially the case for all terminal extubations, correct?
Yes, if a patient is terminal and dependent on those life support measures, yes.
So, after someone is extubated, what do you do when you, after the medication's given and the extubation takes place? I know you said some family members stay, some leave. What do? You go to your office?
No, I'm typically still in the ICU, and it's, again, the ICU is a very fluid place, so there may be other patients and needs that need to be attended to. I will typically check back on the patient and see how they are doing and how their family is.
If a patient is actively dying on life support, well, let me backtrack a little bit. A patient can die while on life support, right?
Sure.
So someone could have a ventilator and vasopressors and they can still die.
Yes.
Okay. And if someone is actively dying while on these life support measures, then as a doctor, you feel compelled to go to the family and let them know that this is a very distinct possibility, right?
Yes.
And that time is of the essence to make a determination whether they want to die on life support or have the tubes removed, correct?
That's right.
So if they are actively dying, that becomes an emergent situation, right?
Could you maybe rephrase it?
Sure. If a patient is actively dying while on life support system, while on vasopressors and mechanical vent, if they're actively dying while that happens, it then becomes an emergent situation to make that determination. Are we going to take off the bed, or are we going to leave him or her on, correct?
Yes and no. I mean, because what's going to happen is going to happen at that point. We do try to clarify pretty emergently with the family what I had talked about, that DNR CCA, because if they're what we call a full code, meaning we do everything, then we would be performing CPR and all of that in those cases. So that part of the conversation is done urgently to make that decision.
Right, and if a patient is dying on life support, you have to let the family know, right?
Of course.
And at that time, they have to make a decision, correct?
Right.
And sometimes, depending on how ill the person is, and I know it's patient specific, that becomes an emergency, right?
Again, but things are going to, you know what I mean, we still support the patient and respond
I'm
to
aware of
that.
that, but it becomes an emergency, right? Time becomes, let me rephrase that to make it easier. Maybe you might like this question better. Time is of the essence now, right?
To a point, but we don't, even if the family said, okay, we don't want to escalate care or resuscitate them, we don't emergently need to take the tube out. I mean, they may simply pass away, even doing everything we're doing, or by just simply turning off the vasopressors.
And you as a doctor can give them that option to die on the vent or not, right?
If time allows, sometimes patients pass away before we have that opportunity.
That's the point I'm trying to make. So time is now of the essence in that type of a situation, correct?
Objection, asked and answered.
I'll let you have it. Go ahead and answer. Can you answer that?
Yes. Yeah, I mean, it's certainly a time-sensitive situation.
Okay, so there are occasions when a patient, when a patient is actively dying on life support where, I guess you could call it an emergency, right?
Just ask that question.
You nodded your head. Is that a yes?
No, stop. Strike it, ladies and gentlemen, strike the question, strike the answer.
I'm sorry, Judge, I misunderstood you.
Well, you asked the same question again.
My apologies.
It may have been different words, it's the same question.
I got you. Now, you mentioned that depending on the situation, where you go after a extubation, it depends on the situation, right?
Right.
So if a patient is actively dying, you're going to stay close by. Is that correct?
Yeah, I mean, I'm generally in the ICU and everything's fairly condensed there.
Now, you're aware that there's a monitoring station where the nurses can sit after an extubation and see the heart rate and the respiratory rate of the patient, even though they're extubated, correct?
Sure, and we can all see that, not just the nurses, yeah.
Gotcha. So a nurse or a doctor, once the life support's withdrawn, the family's inside with their loved one, can sit back and give them their privacy and still observe what's going on, right?
Yes, with the vital signs, yeah.
With vital signs. And they can make a determination by looking at that, whether the heart stops first or whether the patient stops breathing, correct?
You can, but sometimes the respiratory rate slows quite a bit and then they may take a breath, so there's some variability to all of that.
But you can definitely see when the heart stops, right?
Yes.
And then you can also, depending on the situation, can tell whether they're still breathing after their heart stops.
Yeah, I mean, these things happen sort of simultaneous. It's, I don't know how much we pay attention to what stops first. I mean, the bottom line is the patient has passed.
And also bottom line is clinically, when a patient's heart stops, that's when you determine the time of death, right?
Correct, yeah.
Now, you mentioned that you have dealt with pharmacists in the past where they come to you and they ask you questions about medication or sometimes tell you they're not accepting that medication, right?
Yeah, it's usually collaborative as opposed to that they're not accepting.
Now, as a prescribing doctor, is that something you rely on when you give an order for medication, that at some point, someone who's trained in a different area than you is going to be looking at this, and if there's an issue with it, they'll bring it to your attention?
Yeah, I mean, it's certainly something I'm aware and appreciative of. I'm still ultimately responsible for every order I place.
And you're also aware that a pharmacist is responsible as well for their end of the process, right?
Yes, yeah.
Now, just want to make sure I have everything that I covered with you. Now, as it relates to Ms. Balasari, you were in fact the doctor who initially had the conversation with the family as to what Ms. Balasari's preferences were in terms of life support, right?
That's right.
Okay. And you noted that in the chart as well?
Correct.
That's something you would write in your progress notes?
Yeah, or sometimes a separate note, like a separate family meeting note, where I'll expound on the discussions.
And you also had the conversation with another patient by the name of Tracy Young. Did you not?
I'm not familiar with that.
Okay. Are you familiar with the name Tracy Young?
I know it's come up in this case, but I have not reviewed any records, and I don't recall that case.
Okay. Can I get that chart? While he's getting that, you said that you're aware that it came up in this case, that it's come up in this case. Has anyone from Mount Carmel ever come to you and discussed let me just strike that. Has anyone from Mount Carmel ever come to you and discussed this patient, Tracy Young?
Objection.
No.
Hearsay.
Oh, she's already got it out. No? Do you still want to maintain your objection?
I'll withdraw it.
Okay. Continue on.
Okay. What about law enforcement? Has law enforcement ever spoken to you about Tracy Young?
Objection.
Okay, but he's not asking what was said, so has anybody from law enforcement approached you about this matter?
No. Well, I mean, about this particular patient? Is that what you're asking?
Correct.
Not with respect to this particular patient.
You, in fact, did have a conversation with law enforcement, though, right?
I did.
And it wasn't until 2020 that you actually had the first opportunity to have any conversations with law enforcement, correct?
Yes.
So it was like a year after they had arrested William Husel.
It might have been more. I think it was October of 2020, so
So
more than that.
a year and a half,
Yeah.
year and a couple months, right?
Right.
And when they came to you, they never asked you about Tracy Young at all.
No.
Now, I want to see if I can have, hang on. Make sure there's a conversation.
Tracy was in the locker, but everything else in that locker got taken out, so I don't know what you do with it.
All right. That's okay. Okay. If I showed you your progress note on Tracy Young, might that refresh your recollection as to perhaps whether in fact you spoke with the family about removing care?
It may. Like I said, I haven't had the opportunity to review any of this patient's case before.
Your Honor, can we approach, please?
Yeah, we can. Ladies and gentlemen, find out something new about your person next to you. David? Okay. I'm still trying to figure that out.
this road was I
got donuts. What more do they want? It's like Lay's potato chips. Can you eat just one of those things? Still hungry? Yeah. Tell me when you're ready. Let's try us.
Really quickly, I'm going to show you your progress note and see if it helps refresh your recollection, and then we'll discuss it a little bit.
Sure, that's fine.
All right? May I approach?
May.
Thank you. If just, you don't mind giving me a couple minutes, because I haven't
Take
reviewed
your
this
time.
before.
Do what you need to do. That's fine.
Yes.
Okay, let me put that in front of you.
Sure.
Okay.
No. Do your work first.
Sure. Now, ma'am, you had a chance to review that record, correct?
Just now, I have not previously reviewed her records, though.
Okay. Did that refresh your recollection as to what you did on Miss Young in this particular progress note?
It does to an extent. It looks like that was 2014, so we are going back
Yes.
quite a ways.
Yes. And I definitely want to point that out. May I publish?
It depends. Well, there's an objection. Hold on. Can I see it?
You want to see it?
Yeah,
Oh, sorry.
since I'm the one making the call. So you're just going to talk about the first page?
Yes. Not really diving too much into this.
Okay. I'll note the objection. I said I note the objection.
Okay. Dr. Moody, showing you what's been marked TY page 111 through 112. And specifically, this is a progress note of yours, correct?
Yes, a code blue note specifically.
And looking at the date here, this would have been entered in November 23rd of 2014, correct?
Correct.
And that is before Ms. Balasari's, who is the count one in this case, on 2015, right?
Yes.
Okay. So, in this note, I guess, it basically talks about the code blue that Ms. Young experienced, is that correct?
That's right.
And subsequent to that, you met with the patient's mother and sister, correct?
Yes, along with the palliative care team and the chaplain.
And the chaplain and the charge nurse were
Yes.
present, correct?
Yes.
So multiple people are present during your talk,
Correct.
okay? And you basically gave them Ms. Young's prognosis, is that correct?
That's right.
Okay. And you state that you will defer to the timing of this to the family.
Right.
Now, ma'am, when you, as a doctor, some of the three things that you rely on are your education, correct? Is that a yes?
Yes. Sorry. Yes.
Your experience,
Right.
correct? And whatever literature or studies there might be out there that you can access, correct?
Sure. Things certainly become updated as years go on.
Because doctors study and conduct studies on all sorts of things, correct?
Correct.
It's an ongoing science.
Yes.
Okay. And fair to say, equally qualified and equally trained doctors can have two completely different opinions, right?
Yes.
Okay. And one could be right, one could be wrong, or they could both be right or wrong, right?
That's fair.
Okay. How important is your experience with patients to you?
It certainly resonates, and I learn a lot from each case.
Is it what you rely on to continue to practice medicine?
Not entirely, but it's certainly a component of it.
It's a factor.
Yes.
And if you, I know during direct examination you were asked about your experiences and what you do during palliative withdrawals. If you conduct something, if you utilize a certain drug and it doesn't quite work out the way you had initially anticipated, you take that into consideration for the next patient, don't you?
Yes.
And if you also, on the flip side of that, if you give some medicine or a dose and that works out well for the patient, that's also something you consider for the next patient, right?
Yes.
Now, you were shown and discussed a little bit about how things have changed, or that there's now the order sets are mandatory
Right.
at Mount Carmel, correct?
Right.
Now, subsequent to this changing, now you're required to follow a certain set of orders, right?
That's right.
Okay.
Well, an order set. There's options within that order set.
An order set. And you're also required to follow a certain amount of policies too, correct?
Sure.
Okay. You, in fact, have had a bad experience utilizing those new procedures, right?
I don't know specifically what you're referring to.
Sure. I got to show it to one more. Judge, do I have to show to their entire prosecution team?
Well, she handed it to him. I guess he's kind of stuck, aren't you?
Well, yeah, Your Honor, you run the courtroom, but I can consult with my fellow prosecutors, sir.
Okay.
I'll give them a minute to huddle, Judge.
You You guys want your break because it's coming close.
No, I don't think we've seen this before from the defense. So I just,
Okay, hold on, stop. You guys want a break? No? Well, I'm gonna end up in a sidebar here in a couple seconds, and you're gonna have to talk to David. Why don't you guys give me a little bit of loving on this one? Take the break. Okay? David?
All rise.
Sorry to be so demanding. It's like I'm a husband, right?
you'd understand. Take a break.
doctor at bedside. So for that reason, this shouldn't have been introduced to begin with, but they chose to. They made that affirmative decision to do that, and as a response, we should be able to say, well, okay, yeah, that's the new policy, but look, there are some consequences to that policy, and this is one of them. And that's it. We're not making this a mini trial as to the the remedies that they've utilized. But these 2 or 3 questions, and that's it. Then I'm getting back to what should be introduced into this case. I didn't bring that evidence in, they did. And I just simply feel that we have to respond. I can't leave that alone and in hopes that there's not a juror here thinking in the back of their mind, oh man, these new order sets must be the way it's supposed to be done, so therefore he's a killer. I can't allow that to stand or without addressing it.
Anything else?
One moment, Your Honor. We're just hopeful the witness has amazing ear-blocking capabilities.
May I just clarify that the issues I brought up in here have been remedied in the current order set we have? Okay.
And Your Honor, I believe that we hadn't yet introduced the new order set. I believe that defense introduced the newer order set and they're crossed earlier.
No, I've never introduced the order set.
Okay.
We did
Yeah.
A&P, we didn't do C.
No, I didn't. No, C.
C was shown as well.
No, C was shown. It's marked as State's Exhibit. I actually had never seen the order sets, to be honest.
Do new order sets remedial in nature? She's trying to change a remedial moment. No.
I'm saying, who did we show it to?
You made your record.
16 Janet showed up.
I'm sorry.
Okay, you've made your record. I'll step off. You can proffer away.
Are you saying that I can't ask her about this?
No, you cannot. We're compounding something that's already by rule, 407, it's not admissible. We're compounding it even more.
Then what we would like is to strike this order set from being entered into evidence and
The new orders, the remedial one.
Yes, the remedial one, and with an instruction to this jury that they are to disregard this new order set or any mentions that have been made in this trial about that. I think that's the only way you can cure this issue without prejudicing Dr. Husel.
I have one here.
Help me understand that argument. What's the prejudice to Husel if it's a remedial action after the fact?
Because it's evidence that's being considered in the guilt phase of his murder trial, Judge. I mean, the state brought it in for a reason because they believe...
See, I don't think the state did, but that's for the transcript.
It's marked State's Exhibit. We didn't mark it.
It was marked.
And I can recall them bringing it up. Ms. Menashe recalls it. I would not be addressing this issue if I didn't think it came up in the trial. Wouldn't care.
Anything else? I'll step off, proffer your record.
Okay. Judge, I think I've proffered our reasoning behind it already.
Well, proffer, I'm not supposed to be there. If there's nothing else you wish to add to what's already been said on the record?
Do you have anything to add? I think I've laid it out for the record. We would be requesting that.
A proffer is never done with the judge present. I know there's judges in this court that think they need to be present. You shouldn't be. That's bad form. This is your chance to open up the record for anything you think I've done, so you don't think I'm being influenced in any way.
No, Judge, I think I've laid out our rationale and our
Okay.
reasoning. I don't think it's necessary for you to step down. I will ask at this time, though, that an instruction be made to the jury. I think the jury is aware of what's transpired here. If for some reason I'm not allowed to go into this, I think that has a negative effect on the defense.
Any objection to a curative instruction?
I've been on before, I'm not allowed to say anything. Right? Is that the
Correct.
rule? Okay. But you can consult. Oh, I'm sorry.
Your Honor, what would you be suggesting as a curative measure?
I'm going to discuss with them that there's a concept under the law called a subsequent remedial measure. It's not to be considered by them for any reason, okay? By law, it's not relevant, and that'll be it.
Could we ask that Your Honor instruct them that they are to disregard the subsequent order set and not consider it in any way? That's all.
Am I accenting it?
Yes, because it's already accented during the questioning, Judge. We took a break during an objection. This is the issue. And if that's the case, then let's get rid of all of it. We pointed it out. Obviously, there are a curative instruction on many occasions sometimes has to direct attention to the matter. I think that...
Any objection then?
Yes, I think like the court said, it's going to draw extra attention to the order set, and then they're going to infer that there's something else. I think it's perfectly sufficient to explain to them. It shouldn't be used for the purposes of anything other than to compare it.
Okay.
We are the prejudiced party, and that's why we would specifically like it to address.
Well, that's an issue for the Court of Appeals here, okay?
I certainly don't hope so.
Okay. I'll add it in, and we'll just get this matter once and done. Is that the last of the question you have for the doctor?
For that, on that topic.
So you have other cross?
Yes, just
Okay.
2 or 3 questions.
Well, I know a judge, if you'd have said that, you'd have locked yourself in.
No, just a couple questions.
That's better. Attorney Huber, you have to excuse us.
No, it's all good.
You're to disregard that whole entire conversation. You just need to be there for it.
It's true.
You okay, Sam?
Just stretching.
We're going to have to all join yoga here, since it was recommended.
I'm still doing it.
It just seems to penalize large dudes. Stretch like that. If I could stretch like that, I wouldn't be here. Okay.
All rise. Thank you. Please be seated.
Ladies and gentlemen of the jury, thank you for your patience today. I need to explain something to you. I usually try to do this as we go through the trial, but this one's kind of come to the forehead. there's a concept in law called subsequent remedial measures. And what that is, you can't hear me? Wow.
Subsequent sign.
Here, let me sit down. A little disrespectful, but I'll sit down. It's the plexiglass's fault. There's a concept in the law called subsequent remedial measures. Now, what that is, something's changed because of an event. Policy, format, something along the lines, okay? Under the law, you can't consider that, okay? Now, in particular, we've been talking about the new orders. You can't consider it. You're to disregard that, okay? Anything for the record?
That's all we need, Judge.
Anything?
No, Your Honor.
So it's as if you never heard anything about the change in orders. Okay, it's not for your consideration. Mr. Baez, continue on.
I'm sorry, Your Honor. I just one moment.
Okay. Tech people. Her fingers were flying while you guys were gone, so.
It started blinking right as I started
Right as I started talking, huh? Is that a sign?
Might be.
Might be.
May it please the court?
May.
Dr. Moody, I want to conclude by asking you about something the prosecutor asked you earlier. You testified on about receiving a phone call where you were notified that Dr. Husel had given 1,000 mics of fentanyl to a patient?
Yes.
Okay. And then subsequent to that, you were asked about reaching out to Dr. Husel. Do you recall that? By the way?
Yes.
Okay. Basically, what you had done was you had texted Dr. Husel and let him know that you were thinking of him and his family.
That's right.
Okay. And you advised him that this was crazy and you couldn't believe how it had spun out of control, and you were so sorry for him and his family.
That's right.
And you also said that you were truly sick of what he was going through and that to please let you know if there's anything you could do. Is that correct?
Yes.
I have no further questions.
Redirect.
Thank you, Your Honor. Dr. Moody, I'd like to direct your attention to the discussions that were had about the death rattle, as defense counsel called it. You said these are a symptom of the secretions. Is that what it was that you said?
That's right.
Are there medications that you give to treat that?
Yes, we can use atropine or some other medications that help to minimize those secretions, but they may not entirely resolve.
And forgive me if I mispronounce this, but what is a nasal cannula?
It's oxygen that goes under the nose.
Do you ever use this for your palliative extubations?
I do, in most cases.
And what's the purpose of that?
Just to help with that transition that I think we talked about when you're going from quite a lot of oxygen to room air. Instead of just room air, that would at least help supplement the oxygen and perhaps alleviate the work of breathing a little bit. There's still a big change in terms of that oxygenation, but it's meant for comfort in those cases.
Okay. Can you tell me the difference between the DNR-CC and the DNR-CCA?
Sure.
Objection beyond scope, cross.
I'm using it as a transition. I believe we were
Okay, I'll
talking.
let you have it.
Thank you.
So a DNR-CCA, and it stands for Do Not Resuscitate Critical Care Arrest, and that arrest is the important word there. We will continue to do everything for that patient, meaning mechanical ventilation, vasopressors, dialysis, other medications to help their heart, etc., short of them suffering a cardiac arrest. So if their heart were to stop, in that case, we would not perform CPR, we would not shock their heart, or give them any medications to restart their heart. We would instead let them pass away naturally. DNRCC is do not resuscitate comfort care, which is kind of like it sounds. It means that we are strictly focusing on the patient's comfort. Not to say that we don't always care about a patient's comfort, but that becomes our only priority, and therefore we withdraw any life support measures that may be keeping the patient alive artificially, such as a mechanical ventilation, vasopressors. We would stop dialysis if they were on that, things like that.
And when you change someone's DNR to a DNR-CC,
Objection, Judge, this is beyond the scope.
Well, I disagree.
does that mean that that patient needs to be immediately removed from the ventilator?
No, but we make plans to do so according to the wishes of the family in that case.
And in your experience as a doctor, have you seen any things to show you that it is improper or bad for a person to die on a ventilator?
Objection.
Okay. Sustained.
Is there a reason why it's not necessary to remove someone from a ventilator immediately after changing them to a DNR-CC?
Sure.
Objection.
No, I'll permit that one.
Go ahead.
Sure. Sometimes a patient, and we've talked about this, may be actively dying, and sometimes simply stopping those vasopressors, they would subsequently pass away very quickly. We talked about paralytics being a medication that keeps you paralyzed, so we need to know that those have been off and out of a patient's system sufficiently before we would take the tube out. So there are certainly several things that it is predicated on before we would proceed with that extubation.
Okay. Thank you. Nothing further, Your Honor.
Okay. Doctor, you may step down. Thank you kindly. You can leave that there.
Okay.
We'll collect it. Who's up? Don't.
Your Honor, I believe that Dr. Woodkey is our next. That is Mr. Zion's witness, and I will bring them in.
Okay. You guys holding up okay? Is it comfortable back there yet? Back in the jury box, jury room. It's okay? I just noticed that one group seems a lot funner than the other. I don't know what's going on here. I won't tell you which one. We were saving it for you.
Thank you, Your Honor. State of Ohio calls Dr. Woodkey to the stand. Yeah. Yeah, I get it.
Doctor, come on down.
Just follow me on it. Oh, you got it, David?
Follow that gentleman right there. Mr. Pedicus.
And just raise your right hand. Do you swear or affirm to tell the whole truth, nothing but the truth, so help you God? Thank you. Please sit and make yourself comfortable. And if you would be so kind as to state your name for the record and spell your name, please.
Deborah Woodkey, it's W-O-I-D-T-K-E.
Thank you.
Doctor, if you're more comfortable with your mask down, you may.
Okay, thanks.
Okay? We had another doctor in there recently, so I don't know. Okay? You ready? Yes. You may proceed.
Thank you. Dr. Woodkey, what do you do for a living?
I'm an internal medicine physician, but more specifically, I'm a hospitalist.
Can you tell the ladies and gentlemen of the jury what a hospitalist is?
So by training, we train in an internal medicine program, but most internists in this day and age either practice.
I'm going to slow you. You're going too fast for me, and I
Okay.
talked to you before, so slow her down, please. I'm going to step back here so I make sure everyone can hear.
Internal medicine physicians are either inpatient physicians, which is a hospitalist, or outpatient internal medicine doctors, perhaps like a primary care provider that you would go to.
All right, and you are inpatient or outpatient?
I am inpatient.
And could you tell the ladies and gentlemen of the jury your education and qualifications to do the job you do?
Well, we will go to 4 years of undergrad, 4 years of medical school, then you do a 3-year residency. Still to this day, there's no fellowship to be a hospitalist. You either decide that you're going to stay in, your interest is in the hospital, or your interest would be to be a primary care provider outside the hospital doing internal medicine, primary care, mostly for adults. It's usually not children, it's adults, older folks, complicated medical patients.
And are you licensed to practice medicine in the state of Ohio?
Yes.
And how long have you been so licensed?
For 24 years.
And are you board certified in anything? You said there's not a fellowship, but is there a board certification to become an internal medicine doctor?
No, you're just board certified in internal medicine. There's different tracks, but internal medicine.
And that's what you're board certified in?
Yes.
And technically, who do you work for somebody?
Well, we're a private group. We're called Columbus Inpatient Care, and we're a group of 41, 43 hospitalists, advanced care practitioners like nurse practitioners and physician assistants.
And so that's a corporation you work for that you're part of?
Yeah.
And does your corporation contract with any local hospitals?
Yes, we contract with Mount Carmel.
All right. And were you so employed and so contracted back in 2018?
Yes.
We've heard that Mount Carmel is a hospital group of 4 separate hospitals. Was there a particular hospital you were working at?
At that time, we were only at Mount Carmel West, some nursing facilities. We may have started at Mount Carmel East at that year. I'd have to think about that. I don't think so, though. I think we were only at Mount Carmel West.
All right. So what was a typical day for you like back in 2018 working at Mount Carmel West?
Well, it is somewhat like shift work in that we'd come in around, the day rounders would come in around 7 in the morning. You get your list. The list is split up by one lead rounder. You see the patients that are in the hospital. Every single one needs to be seen every day in the hospital. And then at 3 o'clock, there's a 1 hour-ish, 1.5 hour overlap between the daytimers, several evening shift doctors, and then an overlap in night shift. We were 8-hour shifts.
Okay. And did you work in the morning shift or the evening shift?
Well, I worked all the shifts, but that mostly on day, a lot of evening, but almost never nights.
Did your group have evening hospitalists on duty?
Yes.
All right. So, as a hospitalist, were you ever assigned the role of attending physician for any patients?
Yes. The way it works is the hospitalist group, patients are almost always assigned to the hospitalist teams. And then typically we would consult as needed. There are some other admitting services in the hospital, such as trauma or general surgery. But the vast majority of patients in any hospital anywhere in the country are assigned to the hospitalist teams.
And you're assigned and then you're assigned as the attending physician for that patient?
The attending would technically be who from my group was seeing the patient that day and that week would be who that patient would specifically be assigned to. But in general, the admission service would say Columbus Inpatient Care, my group.
Oh, I see. So the hospital assigned you to your group, and you said there was 30 to 40 doctors in your group?
Yes.
And then you would be assigned like a particular day or week to that patient?
Yes.
All right. So taking you back to 2018, did you happen to be assigned the attending for a woman named Rebecca Walls?
Yes.
I'm just going to show you the whole thing. I'm going to show you what I marked for identification purposes as State's Exhibit 13. Do you recognize State's Exhibit 13?
Yes.
For the record, it's a black binder that says Rebecca Walls, count 13. Do you know what is contained in this binder?
I'm assuming it's her entire medical record. It's thick.
We had a chance to go over this beforehand,
Yes.
and did it appear to be a fair and accurate copy of Rebecca Walls' medical records?
Yes.
From when you saw her?
Yes.
So what was your role in the care of Rebecca Walls back in 2018, specifically referring to the dates of November 13th, 2018, to her discharge on November 19th of 2018?
I believe that when I don't know what day of the week it was, our week usually starts on a Monday, but I met her, I believe, already as a critically ill patient in the ICU. When I picked up her care, she was already in the intensive care unit, intubated, which means on a ventilator, had already been in very critical condition. So and that happens sometimes. I never met her well. I picked her up already in a very ill state.
What, if anything, did you do with her as your attending physician when you met her in the ICU?
Well, when the patient's in the ICU and we're the admitting service, we have, they're being cared for mainly by the ICU team. We relinquish a little bit of control of our patients when they go in the ICU because we've turned them over to a specialty service, which in this case would be the intensive care team.
What type of structure was the ICU at Mount Carmel West in 2018 in regards to whether it was an open or whether it was a closed ICU?
Technically, our ICUs in Mount Carmel are open ICUs in that the internal medicine admitting team is allowed to follow along when they go in the unit. We're allowed to suggest some things, and we are updated daily. We still see the patients every day in the ICU, but we are required to have a consult to an ICU team.
What does that mean? You have to have a consult to the ICU team.
They don't want a group of hospitalists, perhaps managing ventilators and pressors and complicated antibiotics. They want to make sure that there's a specialty service following the ventilator. They're pulmonary critical care physicians like Dr. Moody, who you just heard for the last couple hours.
You know Dr. Moody?
Yes.
From your work at Mount Carmel. So just to summarize, it's fair to say when they're in the ICU, the people taking care of her are the ICU?
Yes.
All right. So did she ever leave the ICU once you were assigned as the attending?
No.
Did you check in with her every day that she was at the hospital? Did you go in and see what was going on with her?
Yes.
All right. And we're not going to go through this, but what was her prognosis? Could you summarize her prognosis, what her course was, and what the expectations were regarding her recovery?
Well, to discuss her course, I might need at least a discharge summary, but
Your Honor, would it be all right to give that to this witness?
Would that help refresh your memory?
yes.
I'm just going to pull this out.
He was a lawyer. It was
Showing you what's been labeled as the discharge summary of 11, I don't know what this page is. Is that good enough for you? Okay, the discharge summary from State's Exhibit 13. Yeah. What's that? does that help refresh your memory as
Yes.
to what her course of treatment was in the ICU and what her prognosis and expected recovery was?
Yes, yeah.
Tell the ladies and gentlemen of the jury, as her attending, what that was.
Well, she was 75 years old. She had a lot of chronic medical problems, which perhaps I don't have to name them all, but it looks like she had gone to see her internist, who was trained similar to me, but is an outpatient internist, and he saw her in the office, sent her to the hospital for shortness of breath. She had heart failure. It looks like she may have been directly admitted to the ICU. She had a heart cath and had to require a heart stent in one of her vessels. And she had a hematoma in the groin, and she required intubation just a couple days after admission. So at least 2 days into her admission, she's now in the ICU. Again, she became very, very low blood pressure or hypotensive, requiring medications to support her blood pressure. And then she became very unstable, and it sounds like, again, it was a situation where the family was called to the bedside to discuss her declining prognosis, and then she was palliatively, it looks like she was, I didn't say whether or not she was palliatively extubated, but I presume she was made a DNR-CC. That means comfort care only, which would suggest we were going to take away the life support, which would include the pressors and probably the ventilator.
Could you all hear her?
And then
Okay, hold on, Doc. One of the things that's human nature, when you're focusing on something, your voice will go down in volume.
Okay.
Avoid it so they can hear you, because I know they were kind of straining down there at the end.
Okay.
Now, I'm going to stand back here and speak real loud, kind of probably annoying everybody, but I think that sometimes makes witnesses speak a little louder. So you said shortness of breath. Did you guys use a medical term in that document, just in case the jury's looking at that at some point?
Probably dyspnea would be a word.
Dyspnea. Can you spell that for the record? And if the jurors see that term, can you explain what that is?
D-Y-S-P-N-E-A, dyspnea. It's just that. It's a medical terminology for shortness of breath.
Okay. You said she had a right groin hematoma. What is a right groin hematoma?
My assumption here is that she had a heart catheterization. Typically, they either enter through the wrist or the groin.
Slow down.
They typically puncture an artery either in the wrist or the groin. In this case, it was very likely the groin because she had a collection of blood or a hematoma at the catheterization site.
Is a hematoma a doctor's way of saying a bruise?
No, it's more than a bruise. A hematoma is a large collection of blood.
Was that a medically important issue she was having?
Yes.
Okay. And that was is that what we call, the word I'm probably going to say wrong, iatrogenetic issue?
It could be considered, it's a well-known complication after a heart cath, especially since patients that require stents need antiplatelet medications. So I would say it's iatrogenic, but not uncommon.
And if you could spell say it.
Iatrogenic? Oh, no.
If that was going to be a spelling test.
IATROGENIC.
So explain that. Pretend I don't know anything about medicine.
An iatrogenic problem would be a complication of a medical procedure that is well described. And when you sign a consent, when you have something done, they say all kinds of things that could possibly happen before you go get a colonoscopy or almost any procedure. Those would be iatrogenic complications. Bleeding, heart failure, they name all kinds of possible complications, yeah.
Okay. So you've been reading from your discharge summary, correct?
Yes.
And if I may have that back, please, thank you. And I'm going to take this back.
Yeah.
This is stupid. Discharge summary. To me, that is, what does that mean, discharge? Is that when you leave the hospital, I think of, well, I've been discharged from the hospital, I leave with my family. What happens if you die in the hospital? What do they call that?
It's still a discharge summary, but some people will refer to it as a death note, but it's a summary of their admission and their passing. And it's mainly for the medical record, but also for the primary care physician, so they can read the summary of what happened to their patient after. He sent his patient to the hospital, 6 days before she passed, and certainly he was going to look in the electronic medical record to understand what transpired.
Okay. So when we see admit date on medical records and Rebecca Wall, date 13, that's the day she came into the hospital?
Yes.
And if the patient died in the hospital, the discharge date would be that second date?
Yes.
So what date did Rebecca Walls get discharged from the hospital?
I believe it was the 19th of November. Yeah. November 19th, 2018.
Okay. And did she pass during a time when you were there?
No.
All right. So did you come to work the next day, the day after she passed?
I presume so. I came in the next morning. I would have to confirm that, but.
All right, so now you're the attending, and one of your patients that you're the attending for that was in the ICU has passed. Tell the folks what if any responsibilities you have to document the records and or to do anything else in regards to this patient.
So since I was the last attending of record that saw the patient that day before, it looks like she died around 1:30 in the morning. A message would get passed to my group in the night, who would pass it to me during the day to complete her discharge summary, and really more importantly, the death certificate. The last physician seeing the patient is signing the death certificate. So this is important legally for the family and for death records. The death certificate is even more important.
Okay. So this would be the responsibility of the last attending on record to do the discharge summary.
How my group, yes.
It could have been somebody else if it wasn't your week there, right? If she had been she lived long enough and could have gone to another person in your group.
Right.
Even if she had stayed in the ICU?
Yes.
All right. So if your week was up, it could have just been passed on to somebody else.
Your objection, Your Honor, ask and answer.
Permitted.
Yes.
Someone that had never even seen her before.
No. The last person that saw the patient, she actually died at 1:30 in the morning. I saw her the calendar day before.
I see. I see. So even if it was your week up, you would have still been responsible for this.
Yes.
But if you had just come on and been the last person to see her, even if it had been for one day, this would have been your responsibility.
Yes. That's how my group does it.
Your group, and how many do you have in Mount Carmel West at this time?
At that time, maybe 30.
I guess the point is it's a rotating thing.
Yes.
All right, so you're the last one to see her. She died at what time in the morning?
Looks like at 1:30 in the morning.
You get the notification. What do you do to prepare that document that you have in front of you, the discharge summary?
Well, a lot of the final diagnoses of this document and the beginning of the history of present illness are the same as they were in the days prior, because it gets updated from day to day as the patient's progress improves or declines. But usually the last paragraph is the summary of just the 24 hours before the patient passes as they're declining, and what transpired and what discussions occurred and how the patient died.
How long did it take you to prepare that?
Maybe 20 minutes.
All right. And do you ever use the cut and paste option when preparing that discharge summary?
I would say the top of the form, some things don't change, like the final diagnoses, the primary care provider, and the history of present illness. The beginning of the history of present illness does not change.
All right. So you just find your last progress note and then continue on?
Kind of.
Well, I don't want, tell them how
Well,
this
the final diagnoses, yes, they really don't change much. So you can cut and paste the diagnoses. There's not going to be a big dramatic change in the diagnoses.
Okay. You said the last paragraph you would have, is new for this document, the discharge summary.
Yeah, yes.
So if I can publish this to the jury judge since it's been identified?
Any objection, Mr. Nash?
No objection.
Okay.
And just so I'm clear, where should we start with the new set?
With the new
Should we
one.
start here or here?
The end of the first page.
Okay, we'll start with here. There should be a laser pointer up there for you if you need to use it to point to anything for the jury.
Is it there? It looks like a little block. There you go.
All right, so this is what we've been talking about, the discharge summary of Rebecca Walls, right?
Actually, that's the history and physical. I think you have.
Oh, where do I? Oh, I'm wrong. Ours are double-sided. Sorry. I know you. You're right. You're right. Here we go. Discharge summary of Rebecca Walls, right? Did I do that now? Right?
Yes,
And that's you, right?
yes.
All right. It looks like she was discharged or died on 11/19. It says you wrote this on 12/4/18. Or you tell me. That's what I read that as. Why is that date there?
That's true. That's accurate, actually. Occasionally, if a patient passes away in the night, and my last day on service was that day, by the time the message gets to me, or perhaps if I have a couple days off, that's true. I did not do it until the 4th.
Okay, so this is the day you're writing it then, on 12/4.
Well, unless that's when it was, no, that must be when I did it, because that can't be when it was printed.
Okay. So you talked about there's a part that it doesn't change. We're going down this document. Final diagnosis, is that the...
Right. Typically, that would not change. We knew why she was declining.
Okay, so you're just getting this from the previous progress notes?
Yes.
And then we go into the history of the present illness.
Correct.
Using your laser pointer, is any of that cut and paste from the previous progress notes?
Yes, perhaps up to...
Is it in front of you? Is there a little...
There is, but I thought I had to
Okay,
show
yeah,
the... Oh, yeah. I would say... Okay, so she was intubated on the 16th. She remained very hypotensive, requiring pressors.
Okay.
Okay, I'd say starting from overnight on 11/18,
Okay.
she remained...
So for the record, if I could just describe what the witness was pointing at. You're pointing at the last line of the first page of the discharge summary, correct? Starting with overnight, that's the new stuff for this document?
Maybe the sentence before, too, but she remained very hypotensive, requiring vasopressors, and critically ill in the ICU.
Okay. This document goes on. Is this the page 2 of the discharge summary?
Yes, yes.
And so this is all new. Can you tell the jury what this all means, if you can, please?
Okay. So she was hemodynamically unstable. That means her blood pressure was not stable, her vital signs were not stable. She was in distress, not doing well. They had to progressively go up on her vasopressors, rising levels of the medications just to support her blood pressure. It looks like the family was called to the bedside to discuss code status. They changed her to a DNR-CC. That would mean that she went from either a full code or a DNR-CCA to a DNR-CC, which is comfort measures only. Typically, that means the family is choosing to either withdraw or not stop going up on vasopressors, and probably it usually also means extubate the patient, remove the ventilator with the family present.
Okay. And go on. And then what you say right there.
So, and then she died at 1:30 in the morning with her family present. And then I noted that I'd already signed the death certificate, because that's always the big question: who's going to sign the death certificate? That's much more. And I'm happy I've already signed it because I didn't dictate this till 2 weeks later, so the death certificate is needed before that.
Why is the death certificate so important?
I'm not sure I just know that the funeral homes, they can't proceed with funeral arrangements, and certainly not if the patient is going to be cremated, they can't cremate the remains until the death certificate is in hand and acceptable to the coroner.
You were, in reading and describing the new part of the discharge summary, the part that was not cut and pasted, you were saying, I was told, I'm assuming, why? Are you there when all this is happening?
No, I very likely got a quick checkout from my night team in the morning that said your patient passed away in ICU bed, Mrs. Walls in ICU bed 3, passed away around 1 in the morning. It sounds like the family withdrew. I get a checkout. We do checkout at shift change. So I was not there, but certainly somebody told me that. I didn't.
Okay.
There's no way I could have known the family was present.
All right, so for purposes of medical diagnosis, someone told you this information and then you put it into the medical record?
Correct.
You said, I have already signed the death certificate, showing you what I've marked for identification purposes as States Exhibit 18N. You guys can use these. So we've got them for all patients. If I may approach the witness, Your Honor. Showing you what I marked as 18N. Do you recognize this document?
Yes, this looks like her death certificate.
Okay, is that your signature on that?
Yes.
Does it appear to be fair and accurate?
Yes.
May I publish, Your Honor?
You may. I assume there's no objections.
Do you have any objection? Yeah. Here we go with States Exhibit 18. That is your signature here in the middle under the 26A certifier name and title?
Yes.
All right. And what date did you sign this?
11/26 of 18.
So how many days, there's what, how many days in November? 31, right? 30? 30. There's 30 days in November, so that's 11 days. Well, how many days after is that then?
7.
7 days after Ms. Walls actually passed, right? And that would have been 5 days before you wrote the new part in the discharge summary?
Yes.
Okay. So did you write in this stuff here? Has to, let me see if I can, in part 28, has to immediate cause, and then list any conditions, something to immediate cause. Did you write all this stuff in here?
Yes.
Can you explain to the jury where you got that information from?
Well, that's her diagnoses. That's her main diagnoses that contributed to her death. And they want to know, they want the most recent one to the oldest one, in that order. The first one should be the most recent one. Diagnosis, that is.
Did you make any of those diagnoses yourself?
No.
Who made those diagnoses? Where are we getting that from?
Well, I mean, what do you mean make the diagnoses?
Did you even examine, I don't want to say you didn't do your job here, I'm just saying, you said she was in the ICU already when you saw her.
Right.
So did you say, oh, this is what's wrong with her, or are you getting this from what other doctors have said is wrong?
It's a team of doctors have diagnosed her with these problems.
Okay. So, yeah, you're getting it from States 13, from the medical records.
Well, that and just the facts that we have echocardiograms and she's on dialysis. I mean, there's a lot surrounding these diagnoses that support them.
Yeah, I'm not trying to question, I'm just trying to, where does that knowledge that you're writing down come from? It comes from the whole team, that's all, right?
Yes.
All right. let's, you use some abbreviations just in case the jurors have some questions. Heart failure, that's where she needed the thing to go up in her leg and caused a bruise, or caused the blood.
Actually, that was the third one. She had coronary artery, number 3, she had coronary artery disease requiring a right coronary artery stent.
Okay, so CAD stands for coronary artery disease.
Yes.
And then RCA stands for?
Right coronary artery.
Okay. And then this was by history, the last one there?
Right.
And what does a C with a line over it mean?
With. She had a history of bladder cancer and had been diagnosed with a recurrence.
Okay. So when she got here, she used to have it and then it had come back? Is that what that means?
Prior to the admission even, they knew this because I wrote months, so that was known when she came into the hospital.
Okay. And what's acute renal failure requiring dialysis?
She had progressed to renal failure requiring hemodialysis. Her kidneys were not working, and she had to receive renal replacement therapy.
Okay. And then this last one, acute, what's that?
Congestive heart failure, and she had a severely tight aortic valve, a stenotic or a tight aortic valve, which caused her to go into heart failure.
Okay.
Those were all fairly new diagnoses.
Those were what?
New diagnoses.
By the team at the hospital?
Yes.
All right. So when you're preparing the discharge summary on 12-4, you say this was, the first part up to that last sentence was cut and pasted?
Probably.
And then the last bit was what you were told by whoever you talked to in the morning?
Probably.
Did you go through States Exhibit 13, page by page, in making your discharge summary?
No.
Did you go back here in the section labeled Medication Administration Record? For the record, this is from States 13 for Rebecca Walls. It's Medication Administration Records. It begins with an entry, administration date time of 11/18/2018 and 1949 Eastern Time. Did you go back and look at this document?
No.
Would that ever be your practice to do that?
No.
And I'm sorry, on the back of that, does that list the amount of fentanyl she received on 11/19? I'm not going to ask you to tell what it was, just is that what the fentanyl is she received on 11/19?
Yes.
Okay. Were you aware of any of that when you wrote that discharge summary?
No.
Were you aware of any of that when you signed that death certificate?
No.
Is that your practice to do that in cases like this?
No.
I'd like to talk to you about patient Melissa Penix, States Exhibit 14. Do you recognize States Exhibit 14?
Yes.
We had a chance to look at this. You had a chance to review these?
Yes.
And what are these, please?
Well, that's her whole electronic medical record, but including, you had specifically had me look at her discharge summary and her death certificate.
Right. Do they appear to be fair and accurate?
Yes.
And when you say her whole medical record, we're referring to an admission between 11/15 of 2018 and 11/20 of 2018.
Yes, that's what I meant.
Okay. Same thing, you're the assigned attending. What do you remember about Melissa Penix that you could share regarding your treatment of Melissa Penix?
I remember more accurately because when I picked her care up, she was out on the regular floor, not in the ICU, not doing well, and she had pneumonia, she had a lot of other things. If you want me to go through all those, I'd have to have that in front of me.
Yeah,
but
you need that in front of you? May I, Judge? If that helps refresh your memory. Any objection, Ms. Menashe?
No, please.
Okay, so I'm just going to give her the discharge summary. Is that what you need, or do you need the whole?
Sure, the discharge summary would be fine.
Just gonna remind you.
No, Roach.
When she was first admitted on November the 15th, she was actually on a regular medical floor, not doing very well, but she had multifocal pneumonia, she had heart failure, she was coughing up blood, and she was on blood thinners.
How many blood thinners was she on?
How many?
Yeah, was she on more than one?
She was on Eliquis and Plavix, and aspirin. She was on 3 for a while. So she was coughing up blood, and that would be normal with a pneumonia in multiple lobes of your lung. She was going into kidney failure. The biggest issue is she was going into progressive respiratory failure from a really bad multifocal pneumonia that grew a very bad bacteria that patients often don't survive. And then I conferenced with the family every day, and she declined, and we discussed that she was going to need a ventilator. She was failing, she was tiring, so I transferred her to the ICU in the daytime during my shift. And this is her death note, but she didn't, she went into the ICU, she got intubated. We had continued everything, antibiotics and ventilator support. And then again, so in the morning, I can't come in the next day. She'd been palliatively extubated in the evening, and she expired rather quickly, I write. And then I put the time of death and that her family was at bedside.
Does that appear to be fair and accurate recitation of the course of her treatment in your mind and this discharge summary?
Yes.
Your Honor, request permission to publish.
Any objection?
No, no.
All right, so once again, from states should be 14, the discharge summary. So this is the date she would have been come into the hospital, and when we say discharge, we mean that's, if she dies, that's the date she died, right?
Correct.
11/20. That's you, right?
Yes.
And who's this guy?
Dr. Runzer would be her internist, who is her outpatient internist.
So that's like, I don't know if people still use it, like a family doctor, like the guy I go to for my checkups, or anyone goes to for their checkups?
Right, but internal medicine instead of family practice, yeah.
Okay.
Her primary care provider.
Okay. And for the record, that's Gregory Runzer, R-U-N-S-E-R?
Yes.
All right. And he just went through the final diagnosis. In preparing this document, and it looks like you electronically signed this on 11/26, right?
Can I add that when I signed it may not have been when I dictated it, because these dates seem kind of far off. I may have dictated it, and then it goes through medical records, and I signed it on that date, but that is accurate. That is when I signed it.
Okay. You might have prepared this anytime between her date of death and that
Right.
date of signing. Got it. All right. Is this part up here, the final diagnosis, is that cut and paste from the other medical records?
Very likely. That probably did not change at all.
Okay. And then history of present illness. Now, unlike Ms. Walls, where she's in the ICU already, you got to interact with Ms. Penix. So is this from the medical records, or is this all brand new here?
Oh, no, still most of it is from the medical records. And then at some point I peel off into what happened that day that I moved her to the ICU. And I have the hindsight at this time of dictating this. I will have known that I sent her to the unit, I went home at 5, I came back the next day and she had passed.
Okay.
So there is a little bit of hindsight in my dictation here.
All right. So when you're talking about what happened to her regarding her respiratory biofire, what's that? I don't know what that is.
It's just a panel to more accurately figure out what is causing her respiratory failure, her pneumonia. We used it a lot during COVID, too. It's just a very common respiratory test.
Okay. The family gathered at bedside after we had transferred her to the unit. So this is all, how did were you there for any of that?
I believe we intubated her before I left that day. We brought her to the unit, she was put on the ventilator. as I recall, the family struggled with whether or not she would have wanted this, but again, they needed to gather family to discuss.
Okay,
And we didn't really have time to discuss too long because she was going into respiratory failure.
all right. So this part where she was palliatively extubated, were you there for that?
No.
All right. And, yeah, because what in military, this is, the time of death was,
10:50, just before 11 p.m.
okay, on 11/20, so you are not at the hospital at this time?
No.
So how would you have found out about those things?
Again, the next day, my team, this would have gotten past my evening team / night team, and they would have let us know in the morning. We would have printed the census, my patient wouldn't have been on the census, and usually that's the first, one of the important things we communicate to each other in the morning.
Yeah, and someone passed away.
Yeah.
All right, so that would have been, once again, information given to you by your team.
Correct.
Is that right?
Correct.
All right. And so all of this last sentence, this is just one of those, you say discharge summary when someone dies. I would be happy to sign. Why are you saying you'd be happy?
I will never dictate that again, but I'm never happy to sign death certificates. But the reason we identify who's going to sign a death certificate is, again, it's an important legal document, and the chaplain immediately needs to know who will be, right after the patient passes, they chase down our team, who will sign the death certificate. They need to give a name and contact information to the funeral home for a physician who will be signing the death certificate. In this case, it definitely should have been me. I knew her for days, several days before she passed.
So if the chaplain's looking and he can look in the MER or whatever and say, oh, got to find Dr. Woodkey, she said she'd be happy to sign this.
Right.
Got it. Okay. And then looking at State's Exhibit 18N.
Yes.
Do you recognize State's Exhibit 18N?
Yes.
And what is State's Exhibit 18N?
It's Melissa Penix's death certificate, listing her causes of death. Just shortened version of what I had on the diagnoses from the discharge summary.
Thank you. Fair and accurate?
Yes.
Your Honor?
No objection?
So once again,
I'm sorry.
I said no objection, and she said no.
I can't hear her. And I
Okay.
can't suppose. So can you speak?
Did that accurately reflect the conversation?
That did.
first time you ever been told someone.
I didn't know someone could hear.
All right, thank you. Publishing now 18N. And once again, is this your signature halfway down under certifier name and title?
Yes.
All right. And you signed this on 11/26, is that right?
Yes.
And the cause of death is, if you could, that you wrote down?
It's MRSA pneumonia would be methicillin-resistant Staph aureus. It was a resistant staph bacteria. Her second diagnosis is Candida esophagitis,
Is there a common term for that disease?
like a yeast infection of the esophagus that we see mainly in immunocompromised patients.
Is it also called thrush?
Well,
No, I don't know. That's just what I was told.
when it's in the mouth, it's thrush.
Oh, okay. So where was this on her?
In her esophagus.
Oh, so this is like down her throat. Okay.
Yeah.
It's a yeast infection in her throat. Okay. And what's this?
Coronary artery disease,
All right. And then what's that mean?
an arrhythmia, atrial fibrillation, probably why she was on the blood thinner when she came in.
Okay. So what killed her immediately was the pneumonia she had developed. 2 weeks.
Yes, it was a slow decline, but yes, the MRSA pneumonia would be considered the main offender to her death.
All right. And then what's this little two squiggly lines and 1 month mean?
Approximately 1 month. She had that prior to admission.
Okay. And years, are you just, is that precise at all?
No, just again, they need to be ordered in the most immediate to the most remote in diagnosis. It doesn't have to be exact.
So certainly an important legal document for all the reasons you've said, but you're doing the best you can with approximations as to cause of death here.
Correct.
Once again, referring to States Exhibit 14, we've gone over the discharge summary. You go back into what's called the MARS, the medication administration record. I mean, I know this is all electronic. We got this all in a notebook. But did you go on the computer and look at the MARS for the amount of midazolam and fentanyl she was given at the time of extubation?
No.
All right. So showing you the medication administration record from States Exhibit 14, the last page of that, 11/20/2018. When preparing your discharge summary and/or signing that death certificate, did it occur to you to go back and look at how much fentanyl and midazolam she was given?
No.
It was available to you if you wanted to, right?
Yes.
Is that ever your practice in preparing discharge summaries and/or signing death certificates in cases like this?
No, that would not be normal practice to go search through the MAR after a patient passes.
Why not?
Well, it just would be extreme, in my opinion, we see thousands of patients a year. It's just extremely low yield, especially in a situation like this, that both of these two patients we're discussing and all the patients that my group saw these were very expected deaths. They were not, there was no surprises. Perhaps if there were some questions, you could. Again, I don't even know where in the EMR that form is. I've never seen it before. But it's available to us, but it is not normal practice to go search back through those records.
In your practice and in the practice at Mount Carmel West, do you assume good intentions in those you work with?
Of course.
I have nothing further.
Ms. Mashing?
Do you want any of these up here?
No.
Okay.
The exhibits, yeah, just
Yeah, these, you don't need these.
One moment, Your Honor, while I get my exhibits ready. Good afternoon.
Good afternoon.
For the record, we know each other.
We do.
Socially. But we've never discussed your testimony in any way, Ms.
No.
Want to start with the discharge summary in Rebecca Walls, if we could. Showing you what I've marked as Joint Exhibit 13, page 7 and 8. I know you had indicated with a pointer just which sentences or lines you had, quote, cut and paste. I just want to make sure I understand the process. You dictate the discharge summary report, do you not?
It's a drag-in, so it's a combination of typing, electronic. You can cut and paste parts that you want, and some dictating.
Okay, so let's talk about the part where you can manually, if you will, cut and paste something.
Okay.
Is that how you indicated you did this first portion here? Is you manually cut and pasted?
Probably. I wasn't expecting this question. I'd have to look at my last progress note to say for sure, but this looks like the beginning of her hospital admission, the story of when she came in, that was very likely cut and pasted the very first section there.
Okay. And fair to say, though, you understand as the attending physician when you're doing a discharge summary that ultimately you're going to have to put your name on it. You understand that?
Yes.
And so when you're cutting and pasting, fair to say that you read in advance what you cut and paste.
Yes.
Okay. And then after, and obviously you cut and paste from the EMR, right? From the electronic medical record of the patient.
Yes.
So you're reading that as well. Certainly you have access to the patient's electronic medical record.
Yes.
Do you review the sheet of a patient that says significant events? Is that a sheet that you would review?
I'm not sure.
Okay. Showing you what has been marked as Joint Exhibit 13, page 935. Does this look as if this is a significance event page for Rebecca Walls?
Yes.
Okay. And I just want to scroll down and see if this is the type of document that you might review when dictating your portion of the discharge summary into the report.
I see that this document exists. That is not something I would normally review. We speak to each other. I look at the progress notes. A lot of this was reported in some of the progress notes. But no, I do not review the significant event report.
Okay, but you would look at the progress notes in the EMR?
Yes.
Would you look at all of the progress notes or just the most recent progress notes?
The most recent ones from the day before when I saw the patient.
And then in addition to your review of the progress notes, the most recent ones, you also have conversations as a matter of practice with someone from your team that tells you about what happened?
Yes.
And then as a result of that review of those progress notes, other documents in the EMR and conversations, you dictated the beginning at overnight 11:18, she remained, et cetera?
Yes.
Okay. And I asked you about whether you reviewed that significant event because you included this information here that the family was called to bedside to discuss the code status.
Yes, and I'm telling you that I very likely was told this from my colleagues who are present in the hospital. I probably did not review the significant events report.
And fair to say that given that you work for the group, you work in a team, do you not?
Yes.
And you rely on one another when you're not at the hospital, that a team member is at the hospital, that you communicate with one another to share information.
Yes.
And I remember during your direct examination when the prosecutor asked you, for instance, about the final diagnosis of Rebecca Walls, and you asked to see the discharge summary. Do you remember that?
Yes.
Because fair to say, absent the prosecutor showing you this discharge summary, you didn't have any independent recollection of the day before when you saw Rebecca Walls, correct?
At the time I dictated this?
No. Yes, now, current day.
No.
And so the discharge summary, part of its value, is it not, is it summarizes the most important events.
Correct.
And I want to do the same thing, if we can, with Melissa Penix. And I'm sorry, let me just make sure on Rebecca Walls, and I'll put it up so we're clear. She had kidney, heart, and lung failure, all three essentially.
Yes.
And even had, and I just want the jurors to understand this, TAVR, am I correct that she was actually slated to have a valve replacement in her heart.
That's accurate. It looks like they were trying to stabilize her enough to try to get that done, but obviously she never stabilized.
And so she couldn't have the TAVR surgery on her valve.
Correct.
And what does the aortic valve do for us?
Well, the aortic valve is, the main valve is when the left ventricle squeezes, blood rushes out your body. The final valve, it's in a high pressure system, and she had a very tight or stenotic aortic valve.
And that could cause heart failure, could it not?
It causes heart failure, and it'll eventually cause death if it gets too critical stenosis.
Showing you now what's been marked as Joint Exhibit 14, page 7 or 8. Does this appear to be the discharge summary from Melissa Penix?
Yes.
And same thing with respect to her critical illnesses. She also had heart, kidney, and lung failure.
Yes.
And she's on vasopressors?
I don't know if she got put on vasopressors at the end. Did I comment on that? I don't think her issues were very pulmonary.
Okay.
She became vent dependent. I don't think she got put on vasopressors.
Okay, let me, I should have asked this question. Sorry to toggle back and forth. Rebecca Walls, she was on vasopressors, correct?
Yes, she was.
So, and your notes indicate as to Melissa Penix, there is no note about vasopressors on her. Is that fair to say?
Correct. And for the purposes of the discharge, it honestly would not have, it's insignificant.
And this case, this being Ms. Penix, you were more familiar with Ms. Penix, were you not, than you were with patient Rebecca Walls?
Yes.
Because you had seen her on a regular basis before she passed.
Yes.
Fair to say that this was a declining individual.
Yes.
And you, in fact, were the one that made the decision that she needed to go to the ICU.
Yes.
And indicated here, I just wanted to know, was that when it says I was in contact, can we infer that this is not a cut and paste? This is you dictating into the machine as to what happened?
Correct.
And it says you were in contact with the family every day as to her clinical picture, never began to improve, and she remained on either Airvo or BiPAP and was not even able to eat because of hypoxia.
Correct.
And those were your own observations that you put into the dictation machine?
Yes.
And then you go on to talk about her respiratory biofire was also negative?
Correct.
What does that sentence mean?
Well, we are looking for any other infection or anything else that could be treated to make sure that it was all MRSA pneumonia.
Because if there was something else that could have been treated, you would have wanted to know what it was.
Yes.
And then you note, do you not, the family gathered at bedside after we had transferred her to the unit and intubated her and decided that she would not have wanted to be put on a ventilator.
Correct.
I know that the prosecutor asked you that you weren't present, so it's likely that that information was relayed to you from a team member. Does that sound right?
Yes.
And I just noted, with respect to both of those patients, that you indicated on direct they were very expected deaths.
Yes.
Thank you. Nothing further.
Redirect.
No, Your Honor, I have no redirect.
Doctor, thank you. You may step down. Call your next witness.
Well, Your Honor, for the first time in this trial, we have run out of witnesses for the day.
We went quicker than they anticipated, I guess.
So 3 witnesses in a day, I think that's a banner day.
I hope it's a record we break soon, but that's beside the point. Ladies and gentlemen, you get to go home. Remember the admonition. Let's get started at 9 in the morning with lots of witnesses.
We'll have them all here, sir.
Okay? Have a great evening, folks. Be safe. What's the temperature outside? Jeez. Enjoy your